we got exam a week from Thursday, so practice exam will be posted this Thursday. So yeah, that'll be open, and then review session, I was thinking Tuesday, so it'll be 2 days before. Hope that's agreeable. We'll do the same thing, start at 7-ish on Zoom, record it, will be released. If you have questions beforehand, please bring them along or send them if you can't attend Stat 1. That's all I got for announcements. Questions or concerns before we dive into today's what have you? All right. So the second part on opiates, this is going to be more focused on prescription pain meds, and is definitely, well, as you'll see, a work in progress. Most of it will be talking about that, using opioid medication to treat pain, and then the problems that have developed over the last couple of decades. There's, a few slides at the end. Still trying to figure out how to fit them in, but they're just sort of piecemeal, whatever. We'll go over that as we're going through things. So today, opiates, addiction, and treatment. And to start off with just kind of framing this idea of using opiates as analgesics for extreme pain, thinking about pain in general. Acute pain, I should change that. It's not so much good, but acute pain provides information, right? This is a danger signal to us to stop doing whatever we're doing or to pay attention to whatever hurts so that we can attend to that and hopefully not, grow whatever is bothering our body into a bigger problem, which could be chronic pain. Right? And certain chronic pain, as is listed, are unfortunately part and parcel of certain medical conditions, more modern medical conditions. But the bottom line is that people suffer from these routinely, every day. And it's not just that the pain is bad, it causes other issues. Stress being a big one, changes in behavior, long-term can lead to depression, and definitely tied in with sleep disturbances. So chronic pain isn't just an issue with dealing with pain, it's more holistic. It can affect a lot of other aspects of someone's life. So needing to manage these is very important. However, the current state of meds that we have meds that are good for milder pains like a headache or a skid knee, or we have heavy duty meds for dealing with very serious pain like opioids. Sometimes opiates don't even touch that pain, and that's a whole other situation that's definitely a hot topic in the medical field. But we really just have these tools for dealing with mild pain or severe pain. However, the tools that we have for dealing with severe pain provide abuse liability, or there is potential for addiction, and then all of the problems that kind of fall out from there. So that's the setup for this situation. What kind of, let's try this one. As it says, before 1990, there was a reluctance to prescribe opioid drugs for pain management. It was a different mentality, as well as wanting to give hardcore opiates outside of a clinical situation where you could be monitored, and that were, it was frowned upon in the medical community. However, as I'll show in a slide or two, there were certain changes in the medical community due to studies that were done, as well as just people changing their mind on allowing people to manage their pain more on their own, if you will, rather than solely in a clinical setting, all right? And this was, a good and bad thing due to the fact that people were getting more access to pain management, but then again, the problems that have arisen since those times have stayed around, or we're still learning how to deal with them. Is important. But one of the good changes that happened due to the openness of the medical community to review the way that they were approaching pain is that asking people about their pain became part of a normal doctor visit. So as this shows, along with the standard vitals that are taken every time you go see your primary care physician, people were asked about pain, and the 1 to 10 scale was implemented, as well as you may see now they have scales that were based off of smiley faces. You know, a smiley face would be 0 to 1 amount of pain, a very frowny face with the tears and everything was a 10 on pain, but you were asked, you know, if you were experiencing pain, how would you rate it on a scale of 1 to 10, okay? So that was a huge development because doctors were openly asking patients to give an evaluation of their own pain so they could try and manage this together or give them a tool to manage it on their own. So this was a big step, however. Unfortunately, one of the biggest things that were used were opioid-style drugs, and the situation became what it is today. So outside of just asking for a subjective questionnaire, you know, rate your pain from 1 to 10, if people were at a certain level of the scale that the physician deemed an intervention into the pain was necessary, they would then try to evaluate if this patient was at potential risk for addiction to something like an opiate. A couple of different questionnaires were developed. The CAGE questionnaire was one of them. As you can see here, the patient would be asked questions. Have you tried to cut down on alcohol or drug use? Do you get annoyed when you're asked about your alcohol or drug use? Do you feel guilty about things that aren't being done due to this? Do you need an eye opener to get the day started? So do you need a drink or some type of drug in order just to get going in the morning? So this is known as the CAGE questionnaire for obvious reason that these functional words in these questions start with a CAG or an E. But this is one way of evaluating patients, along with the trauma test, asking if you've had fractures or dislocations, injured in a traffic accident, injuries to your head. These sorts of things were then used to evaluate the patient, whether or not they would be a good or bad patient in terms of being prescribed opioids, right? And the obvious reason would be that those with less of these symptoms or no problem with previous drug use would be a better candidate than someone who had been addicted to drugs or used something routinely. For that reason, that the physician wouldn't want to get the patient addicted to drugs. Well, for the most part. Yes, as these questionnaires would indicate, the patients would then be profiled as being a potential problem for opioids, and they could give them, patients could be prescribed opioids depending on how much pain they were on, as well as how well they did with the questionnaires in terms of whether or not they would potentially become addicted to the prescription pain meds, right? So, this was a gain for sure, but then again, as I keep alluding to, problems happened. And a lot of that revolved around that time because, so for the most part, physicians were good about wanting to give medication to patients that needed it for pain and didn't seem to be a liability or potential future addict. Unfortunately, as the medical community started to allow for opioid use, more frequent opioid use, people started to take advantage of this. So, some of these drugs, Vicodin, Percocet, oxycodone, you can see these are different opioids, some of them mixed with acetaminophen for kind of a two-tiered approach to pain management. However, some of the problems started to happen when specific pharmaceutical manufacturers started to sort of lean into this situation. As it states here, Purdue Pharmaceuticals was definitely the flagship for what not to do with patients in terms of prescribing opioids. As one of the things they did was engineer a delayed release or extended release version of OxyContin, all right, or oxycodone. Came out in the mid-90s, and then what they did was employ a lot of drug reps who would then go to physicians and really push these, saying that the extended release formulation had a low abuse liability. And that was very true at the time. I mean, that type of an opioid was really good for chronic pain because it wouldn't have as heavy of an onset, it would last longer, patients would need to dose less often, and those who just need it for pain management, it really helped, all right? However, as it goes with addiction, a lot of people started to abuse these drugs and use them in ways that they weren't supposed to. I believe I mentioned in the first lecture that a lot of the problems with opioids was when they came in pill form, and the pill form started to be less healing to someone facing addiction. They would start to crush them up and shoot them or deliver them through intravenous administration. And it would give them much more of a high, it would give them much more of a release, and then they became addicted to doing that. And this, yeah, the problem then really started to snowball from there. So this is one of the reasons, I should put this earlier on, but one of the reasons that there was a change in the approach in the medical community for prescribing opioids were due to studies like this. This is a letter to the editor from New England Journal back in 1980 saying, so these two people had conducted some meta-analysis back when they didn't even do meta-analyses, but they looked at roughly 40,000 hospitalized patients and found almost 12,000 of them had received at least one narcotic. And of those 12,000 patients, they found only 4 that had some potential problem or developing an addiction to a drug that they were given. They get a bit more into the specific drugs here. That's not so important there, but the idea here, though, is that there were 2 clinical personnel that had evaluated 40,000 patients, well, really 12,000 patients who were getting opioid drugs, and found that only 4 of them had a problem with addiction from all of that. So their outcome from the study is that there isn't an abuse liability with prescribing opioid medication to patients, because this is a study that shows that this liability is not founded. So, of course, this sort of fueled that opening up to prescribing opioids that happened over the next decade and then into today, whereas now we have a lot of evidence that shows that this might not have been the right approach, due to the fact that, as you see here, looking at prescription painkiller deaths and plotting with sales, as the sales for opioids increased, so did the deaths. Now we're looking at rate of sales and deaths as what? Kilogram per 100,000 sales, deaths are per 100,000 people. And as you can see from the late 1990s all the way through 2013 here, there was an increase in both happening. So this isn't causative data, but it's really hard to overlook this. When you have this much of an increase of a specific drug, and then you have deaths specifically related to that drug, it's hard not to draw conclusions between these two phenomena, right? So along with this issue, not only were drug companies starting to mobilize sales rep in order to push drugs really heavily to physicians, there were these pill mills, they were called. And these 2 CEOs, Procter and Volkmann, were very interesting at the time. And what was happening was they were setting up actual pharmacies that weren't pharmacies, so they would go, especially in rural areas, this happened. where an abandoned business would be taken over and a pharmacy would be set up there. But the pharmacy didn't have anything in it except for opioid drugs from one manufacturer, okay? And people would go, specific doctors were employed around that area and told, you know, you can give prescription for this drug to anybody you want, and we'll give you X amount of dollars for every prescription that you fill, or that you dispense. So then the patients would go to these pill mills, or they would go to these pharmacies, and they would turn over their prescription, they would get a bottle full of pills, and they would go off on their way. Tracking whether they used that or not wasn't part of the equation. It was all about distribution of these drugs. And yeah, as it says here, I mean, we'll go any further into the story, but these two got nailed for this, understandably so. Few slides of statistics to go through, but yeah, that was one of the biggest problems. They were using false pharmacies to dispense these meds, and the pharmacies didn't even have tissues or vitamin C or anything. They just had specific opioid pills, but they were raking in cash by giving these phony prescriptions, and I mean, it was a whole syndicate. But anyways, so what this shows is areas that were highest hit by the opioid painkiller. Yes, please.
Okay, so for the second doctor,
Yeah.
why is his sentence more severe than the first one?
Yeah, you'd have to
for
see
doing the
his
same
involvement in, you would have to read about his involvement in everything. I mean, it was above and beyond just what I'm describing here. There was, yeah, the story is, it's very interesting, but very tragic. But yeah, it's all about their involvement with the story and how much responsibility found both of these two to have in this whole syndicate that they set up. So, right, so in terms of where the heaviest hit areas in the country were, areas that are in this charcoal, dark gray, black color are the areas that were hit the hardest. And one of the interesting things about this through history, really, drug addiction is a lot more involved in cities and lower economic areas of cities tend to be where a lot of drug addiction happens. This time, a lot of rural areas were affected by this drug, and this caused a lot of confusion to people initially, I guess, because these were traditionally the areas that had a lot of problems like this, but that for this specific opioid crisis, this is where a lot of areas that were hit hardest. And again, it was due to the way that the people were being preyed on by the medical community, or these people who were pushing these specific types of opioids. And this is very old. This is about 15 years old, this piece of datum. On the right, I just got this from the CDC site this week, and it shows, as it says, waves of opioid overdose deaths. First one happened at the end of the 90s due to the rise in prescription opioids, and you don't see it that much just due to the fact that it's gotten so far out of control. By 2010, rise in heroin overdose, and so this is when there was a shift between illicit drug use and illicit opioid use started to take back over from prescription opioid use. But the problem was around this time is where a lot of synthetics started to make it onto the scene. As you can see, so I guess I should start there. The black line here is any opioid death. Synthetic opioids is purple, and that comes in this third wave here, a couple years after the second wave, but heroin is mainly here in the blue line, and then commonly prescribed opioids is in the green line. And as you can see, the green line kind of comes up after the 90s and then sort of plateaus, whereas the heroin didn't really start till about 15 years ago. That started coming back into vogue, as well as these synthetics started being used in adulterating these drugs. And that's where a lot of people started having problems with those. But as you see, the third wave really are the synthetics, fentanyl, remifentanil, carfentanil. These are coming on board now, and they're getting even worse than fentanyl. But as you can see, a lot of deaths due to synthetic opioid use just over the last 10 years here. And so this remains a serious issue without end in sight, really. That school down the road in Ann Arbor does a monitoring the future study every year since the 70s. They have given questionnaires to 8th, 10th, and 12th grade students, and the students are asked to voluntarily reply about their own personal substance use, from caffeine, tobacco, alcohol, marijuana, opioids, everything across the board. They're asked to self-report what they are using. And then the actual numbers they publish these every year, and they're stunning and shocking, especially because we're talking about 8th, 10th, and 12th grade students, minors. But then they compile these with NIH and CDC statistics in terms of deaths and overdoses and whatnot. And so what we're looking at here is, and I guess, I pulled this. I used to work more closely in a specific field of addiction, and when building slides years ago, I used this as number of deaths involving opioids, as you see here, and it ends in 2017. So that was a projection. This study came out in 2017, and they were projecting this. But the idea at the time was, we've got this constant increase over the last 10 plus years, and it's only getting worse. I pulled this last year from the same study, and as you can see now, that area is one of the lower points, or it's still increasing now. Apparently, post-pandemic, it's starting to taper off, but it's still out of control, if you will. Because here's the same thing. All ages, there is a distinction by gender between these, but then the blue bars is the summation of everybody reporting. And the bottom line is that the overdose due to any opioid continues to rise. Then I believe lastly here, so comparing these two, comparing prescription opioids versus heroin, so the main street or illicit form of opioid on the street. As you can see, prescription opioids has increased since the beginning of this millennium, is somewhat tapering off, but the issue is that prescription opioids are being combined with other synthetics, as this yellow line, the yellow line shows. Prescription opioids are now being cut with synthetic opioids, and this has really caused a problem over just the last 10 years, that they're starting to see more and more of these cases where people think they're taking oxycodone, and what they're really taking is sodium bicarbonate with too much fentanyl in it. But compared to deaths involving heroin, so similar situation where we're seeing an increase in the number of street doses of heroin that are being adulterated with synthetic opioids. Overall, the trend is starting to decrease. However, the spike from just the last 10 years is hitting both of these types of opioids preparations. So, part of the issue then, as I was saying, I guess there started with, in the 90s, the medical community started to soften up on, okay, we can start giving opioids to people, all right? But then this problem started happening, and it really, by 2010, we're really seeing the issue with overprescription of opioids. However, along with that, there was a hesitancy to treat people who were suffering from opioid addiction. Overdoses are commonly dealt with through benzodiazepine treatments. Some other, rescue medication would just be epinephrine or an adrenaline shot. But in terms of actual treatments for opioids, there was a lot of hesitancy, and it was really just in, about 10 years ago when John Casey in Ohio put a bill together and said, we need to start treating these people and putting the idea of having a rescue drug like a opioid antagonist that were well established at the time, having those readily available. And I think people can see now you can get those not anywhere, but they're around campus. We give them away in our department. But having something like that around is a great tool. A, because you can save a life, and B, there's no harm from it. If you take that naloxone dose yourself, you don't feel anything. If you're not anything, you don't feel anything. And it goes away quickly, and it doesn't have a narcotic effect. And so having it available to the public was a great idea, and this has become, fortunately, it's only been in the last 10 years that this is really, I feel like the country as a whole has embraced this sort of thing, having naloxone, having naltrexone, having opioid antagonists available to the general public for rescue situations is now commonplace. So again, as we talked last time, naloxone is used for rescue situation. Primary cause of death for opioid overdose is respiratory depression. So when you have that CNS depression that happens with prolonged states of this, opioid receptors in that monitor our breathing, our unconscious breathing, are affected and dampened down. So in heavy cases of opioid inebriation, it's not uncommon that people just stop breathing because their body stops giving themselves those signals. But this type of an opioid antagonist can block that and quickly resuscitate people and potentially save a life. As mentioned before, methadone is a common, much more popular years ago, but still is around for treating addiction. And the idea is that methadone can provide curbing of the craving, but then enough of a sated state that people aren't craving the euphoria. But it's all about dosing, and it's all about maintenance with this, so that you can keep people in this sweet spot, so that they're not craving the heroin during, where they would usually have the high spots, but they're not going through withdrawal when they would usually go through the low spots. So this is a good tool for monitoring that, but the potential, there is abuse potential there. One of the big ways that it's curbed is this is really just prescribed in a medical environment. A lot of people undergoing methadone treatment will just go in for daily doses to a clinic and get their dose, and they can go on their way. Methadone can be used as a tool for addiction, but nobody really pursues it because all of the other ones, that the heavier opioids, are more readily available or just as easily available to a lot of people. So that's one of the things that allows methadone not to be used as a drug of abuse. You need a lot more of it than you would get in a clinical setting, and nobody really has that stuff because, you can get fentanyl now and make it. So it's not as big of an issue, but important for our purposes is that this can cause cross-tolerance with morphine and heroin. You can develop tolerance to the sedative effects of methadone, so it would be less effective the longer that you're using it. But the hope with this is that by that time you've used it enough that you've weaned yourself off of the cravings for opioids, and so you wouldn't want necessarily anything because you've been off of the heavies for long enough. And then, as I mentioned last time, where we talked about Suboxone last time, that's the combination medication of buprenorphine with naloxone. Buprenorphine is a partial agonist, as shown here. So you don't get the big highs that you would from morphine or heroin, but you do get relief from craving. And this is the one that is administered as a pill. And the idea is that if you take the pill and swallow it, the naloxone gets broken down in the stomach, or through first pass metabolism. But the buprenorphine is around to satiate cravings from someone. If you crush the pill up and you shoot it, then you only get the effects of the naloxone. It's going to block all the receptors. You don't get any pleasure from buprenorphine. And if you're on anything else, the naloxone is going to block that out. So this is sort of a combination treatment that's, very clever way of packaging this. But it has to be used right in order to get the actual benefits. And naltrexone was the last one. This hits all opioid receptors, another opioid antagonist. Don't worry about this. I should update this. This $1,500 is way more than that now. But this can be used for curbing opiate use. As we talked about, this is being explored with alcohol and its ability to modulate receptors in the VTA and shut down your reward system so that people aren't having the reinforcing effects of these. This is more of a rescue drug really than a long-term type of reconditioning medication, if you will. Okay, so anecdotal slide here. I don't know how to really pitch this one, but I had a student who was a forensic toxicologist, and she shared this with me. We're talking about how one of the things with heroin is, in terms of the illicit drugs you get on the streets, there's a wide range of presentation of this drug. People know marijuana because they know what the flower looks like, and if you're getting a caprese salad like Michael Scott versus an actual bag of cannabis, you'll know the difference between the two. People who are getting cocaine know to expect a white powder, okay? Heroin can be a lot of different preparations, as shown here. These are all isolated from apparently street rips, I guess. This was a picture taken by I don't know what police agency, but they're all different preparations of heroin, okay? And as you can see, they come in the whitest kind to getting dirtier and dirtier into this really, it looks like beautiful soil for growing tomatoes, if you will, but actually shooting that might be something that you would reconsider. And the idea is that there is this black tar heroin that has gained notoriety since the 70s, and it actually does look like a tarry substance. And a lot of this just due to the impurities, as well as when someone was trying to manufacture this from heroin, a lot of these intermediates, the monoacetylated morphines, are coming through, as well as a lot of other impurities, but that's what gives it this texture, the tarry texture and the black appearance in that. So, it's just an interesting anecdote about this drug itself. People are a lot more trusting when they see something that they don't expect it to look like, just because of not only their drive for getting heroin, but it's just accepted to come in a vast array of different presentations. Yes, please.
Does that change its efficacy or abuse potential?
So does that change efficacy or abuse? It absolutely can. It really depends on how much is in there. Like when I guess the first lecture talking about how, in the 70s, there was like 5% actual heroin in a heroin dose that was sold on the street. Now it's it's gone back down, but then over the decades, it then became much more pure, or you would get a lot more of the product. So yes, the abuse potential could be changed by this. However, I'll leave it at that. There is potential that it would change it, but it's all about how much of the actual active ingredient is in there versus all of the other adulterants. Because a lot of things can be carried over and they would cloud that whole, cloud the pharmacology, because it could block receptors or prevent absorption, et cetera, et cetera. So that was a long way around for that. All right. Something else to keep in mind, opiate addiction is complicated by the fact that some people get on this drug just for the pleasure and anti-anxiety aspect of it. So in looking at just the left side of this flow chart, if you will, When undergoing chronic pain, if you are prescribed opiates, people can get pain relief, okay, and that's their reward, or they have no pain, and how would you say it? They're not getting any sort of benefit from the heroin itself, or excuse me, from the opioid itself, other than the good feelings. But if they don't, if their pain is marginal enough that it doesn't affect their daily activity, they don't see a reward in taking opiates, okay? So again, if you have chronic pain and then you feel better using the opiates, these are the, this is a group of people that could potentially become addicted to the actual medication itself, even after they're feeling pain. There's others that after the pain goes away, they don't enjoy the opiates, or they're not experiencing the drive from the euphoria or whatnot, and they'll discontinue their use. So within the population of people that are using opioids for managing pain, there are those that get addicted to the drug and those that don't, okay? That's the bottom line. However, there are people that use opioids, especially the prescription kind, for dealing with stress and anxiety, or they just like to feel good. So they get opiates, they're stressed, they get opiates, they take them, they enjoy the euphoria, then they keep using. They develop a dependence, they have withdrawal when they don't have them, and then it causes more stress. And this is another group that's much more prone to get addicted to opiates, because they didn't have that initial symptom of pain that they were using to modulate, using this drug to modulate, all right? They just went right for the good feelings of the drug. So they are more prone to develop addiction than people who were actually prescribed the opioids for dealing with pain. Okay, synaptic plasticity, we talked about this with alcohol, but this also is true with opiates, so please beware of that. Slightly different slide. They've modeled this in the nucleus accumbens. I've also read about it happening in the VTA as well as PFC. So exactly where this happens isn't as important as remembering that this does happen. So remember, so we're looking at a normal synapse versus a morphine. They're under a synapse after morphine use. So remember, with prolonged alcohol use, we had a shutdown of glutamatergic signaling. Same thing happens with morphine. So the body's going to upregulate the amount of glutamate in the presynaptic terminal. They're going to upregulate the amount of NMDA receptors on the postsynaptic terminal. And then once this is released, they'll have more conductance there. But just remember that there is this remodeling in opioid addiction that mirrors alcohol addiction in terms of the plasticity at the synapse. A body's homeostasis is normal glutamatergic signaling. If that just shuts off, the body's not going to understand. It's going to want to have that glutamatergic signaling, so it'll upregulate glutamate, it'll upregulate the glutamate receptors, and that happens with chronic opioid use. And then, yes, here's our last one. So 2 more in vivo experiments. The tail lift experiment and the hot plate experiment. Tail lift is exactly as it states. So you take a beaker of water, and it's hot water but not scalding. Most people I know didn't want to actually hurt the animals they were working with, but as the study goes, you have your beaker of warm water and you actually take your rodent and you dip their tail down in the water. When that tail becomes uncomfortable, the rodent is going to lift it up, okay, to get it away from the unpleasant feeling. Similar with the hot plate experiment. You can see 4 different variations. So here we have a mouse that's laid out, where they have a hot probe touching its tail, or they have a heat source that's touching its foot. The hot plate specifically, so these are just variations on the same thing, but the hot plate specifically looks like this, where you actually put a mouse or a rat on a hot plate and you turn it up. Once it starts to get hot, they'll lift their paws and start licking their paws. Okay, so as you can imagine, if you were under the effect of an analgesic or a pain modifying agent, the time that would take for you to lift your tail or to start licking your paws or whatever, respond to some pain stimulus is going to increase because you're not feeling it as much, right? As shown here. So control has no drugs on board. Morphine would take away the sense of pain, and so the time it would take for some rodent to lift its tail or to start licking its paws is going to be increased when you're under the effect of that drug. And that can be further applied to some of the other lessons we've learned before. So down at the bottom, same thing happening here. But let's say we have morphine plus an opioid antagonist on board, should go back to the normal control. It's not feeling the effect of the morphine, so there isn't a state of analgesia happening. They're feeling the pain, they lift their tail at the same rate as the control. However, if we have morphine with drug X and we have a decreased amount of response, a longer time than control, but not as much analgesia happening as just morphine alone, we could probably surmise that this is another opioid drug, and this would be an excellent example of cross tolerance. Excellent. So, just some examples. These are two common in vivo experiments used with analgesics, definitely with opiates, and some potential hypothetical data. That's it for us today. Have a good couple days. See y'all Thursday.